Hello and good evening to everyone. I have the pleasure today of speaking with Professor Chris Newton from Kingston upon Hull. And today he's going to be talking about some of the ideas and concepts that are quite innovative with regards to COVID-19. The first thing that I'd like to do is give him the opportunity to introduce himself to us. Thank you for joining us, Chris.
Oh, thank you, Philip. It's a pleasure to be here.
Right. Well, tell us a little bit about yourself. You're a molecular biologist, aren't you?
Yes, I am. My basic, I was going to say expertise, but let's see, cancer research. So I started off in London researching breast cancer. So I was looking at aromatase activity and looking at the role of estrogens in breast cancers. And we were looking at eventually moved over to look at the estrogen receptor and look at anti-estrogens like tamoxifen, and then to investigate the pure anti-estrogens. And those are the anti-estrogens that bind to estrogen receptors and block their activity more or less completely.
So can I clarify this? Is this primarily to do with, say, breast cancer research, or is it far broader than that?
At the time it was mainly breast cancer research, but of course we now we've moved into various anti-estrogens that have partial agonist activity. So you're looking at the selective estrogen receptor modulators. So that's quite an interesting story, because that impinges on what we're going to talk about later, that the receptors function not only with a ligand, but like estrogen, but they function by transducing signals from other pathways. So I then moved from London to Munich, and we were looking there. I worked in a pituitary group, and I had to find a way of working on the estrogen receptor. So managed to do so. And there, what we were able to show is the estrogen receptor works without any estrogen.
Wow. So the pituitary, you said, is more to do with the brain, the gland in the brain that produces quite a lot of hormones.
Yes, indeed.
And function.
Yes, and of course, the pituitary is responsible for producing the hormones that activate the adrenal gland to produce cortisol.
Yes,
is a very major aspect of the immune system and how you damp down the immune system. You can use high dose glucocorticoids. I mean, everyone seems to talk about steroids, meaning high dose glucocorticoids, or the lower doses that are much more controlled, because of course the amount of cortisol is produced diurnally, so it starts off high in the morning and drops down low in the evening.
Yeah,
that's very critical. And then, you have the stress response coming in, but there are parallels between the estrogen receptor and the glucocorticoid receptor, and that both receptors are activated by steroids. So in the case of estrogen, obviously it's estrogens, estro and estradiol. For the glucocorticoid receptor, it's cortisol. But both receptors function by being activated by growth factor pathways. In the case of the glucocorticoid receptor, you have synergism between cortisol and other pathways, and this changes the way the receptor functions, and so it can.
Let me just pause there a minute, because some of the stuff you're talking is pretty high level stuff. So let me see if I can break it down a little bit. So in effect, you're saying that you have on specific cells, they have receptors which bind estrogen, which change how the cell works. But in the research, you were finding that these receptors didn't just bind estrogen, but quite a few other hormones as well.
They act as signaling units for other pathways. So they don't just signal the effects of estrogens, they signal the effects of other pathways. So we were finding, for example, that insulin-like growth factors, in fact, insulin could signal through the estrogen receptor pathway.
Wow.
There's a sort of dual signaling. So you have the steroids and you have growth factor pathways. And the same is now being found for other receptors, especially the glucocorticoid receptor, that there are other pathways that combine with steroids to switch on or switch off different genes.
Yeah. And this is important, especially when we're going to be talking about COVID, because it's similar mechanisms that the virus, I assume, is when it binds to the receptors on certain cells.
Yes, yes, the COVID story. I mean, that's with the spike protein and binding to the ACE2 receptors. I mean, there you're talking about a signaling pathway, the angiotensin renin-angiotensin pathway. So if you've got a receptor, the ACE2 is part of that pathway, and what it's doing, it's breaking down angiotensin 2. Mm-hmm. So there's a very interesting story, because you bring in the ACE inhibitors, which inhibit the conversion of angiotensin 1 to angiotensin 2, and then you have the angiotensin 2 receptor blockers that block the AT1 receptor. Now, there is quite a bit of work on that, suggesting that those could be useful. The blockade of that receptor could be quite useful. So people on heart medications, so angiotensin 2 receptor blockers like losartans and some of the other sartans, may in fact be quite useful, because there we've got a pathway which is linking the, so when that pathway is activated, you actually generate oxidants within cells, and you get a vasoconstricting effect there, because one of the things those oxidants do is they knock out the nitrous oxide pathway.
Yeah. So let me again clarify, because again, this is some pretty high level stuff, is that in effect, we've kind of drifted into the conversation about how the coronavirus specifically targets one receptor, which is important in the balance of how the body deals with angiotensin 2.
Yeah.
And in effect, I guess you're putting forward the point that when this gets interrupted, it impacts on how the blood vessels in the lungs function.
Yes, absolutely. Absolutely. Yeah. I mean, nitric oxide is one of the vasodilators, of course, the principal vasodilator. So if that pathway is well, if the pathway that gets rid of angiotensin 2 is blocked, then you end up with a lot more angiotensin 2. So you get nitric oxide levels will fall.
Yes.
So it may well be that by using losartan, for example, it may well be beneficial.
Yeah. I'm going to take you forward now, because I'm quite interested in the primary focus with some of the stuff with the ultra high dose vitamin C. You went on to then develop SIMA. What is that about?
That was really, I finished at the university and set up a small company, and that was a fee-for-service sort of story. And after that, I really wanted to use my expertise more broadly. So looking at the sort of totality of effects and looking at all the things that I'd sort of learned over the years, and focus down on looking at the immune system, for example. One of the big incentives is I have a family that has, my wife is celiac, she has hypothyroidism. All these things involve, certainly involve the gut, celiac disease, but they involve the gut immune system in particular, and the gut lymphoid tissues. And so I began to look at this and look to see how important the gut is in terms of the microbiome of the gut, and how it alters our immune system in effect, and the knock-on effect of that can be that if you have a changed immune system in the gut, this can affect all sorts of other systems. So I wanted to use some of the experience over the years to bring it into a sort of more holistic sort of approach of looking at bringing in the science more holistically, and so that I was beginning to focus on different aspects of the gut. And of course, one in particular, as I say, was celiac disease, and trying to work out why some people, when there is the genetics suggests that you have a genetic susceptibility, but the percentages, there's about sort of 25% people have that those markers, but by all accounts the incidence of celiac disease is less than 1%. So something else is going on. So it's looking at that as well.
So how did this transition into the focus that you now seem to have with regards to what's happening with COVID-19? Because you almost seemed as though you kicked into action when we started to see all this stuff happening in the past 2 to 3 months. What was that trigger for you?
I suppose it's frustration in many ways. What can we do? We're a bit stuck in. We're in lockdown, and it was really trying to find a way that you could use some of our collective past experience to help. Because I think we can sort of see the end game of this, and we're going to be waiting for vaccines, which may or may not be effective. And I think that's the thing. And we have a huge toolbox of small molecules that we could use, previous treatments. We can repurpose various things, and of course, one of my main interests, which we'll obviously come on to, is high dose vitamin C.
Well, let's go straight into that. Yeah. So tell me why you think this would be of benefit. And when you say this, is it of benefit generally for COVID or for the very sick patients with COVID?
I think we're looking at two aspects, aren't we? We're looking at the virus itself, and we're looking at the outcome of what the virus does, so the later stages of the virus. So we look at the effect in the lung, which is clearly, where the angiotensin 2 comes in. But really, so if you look at the early phases, we really want to find a preventative. We don't want to get to the stage where we need to go into the ICU. We need to find things that sort of bring us back from the edge. And that's one of the interests, and it's a sort of, that it's going back to my interest in the past, trying to look at ways to prevent the inevitable, if you like. And I chat often with a very good friend. We talk about a traffic light system, and the green, amber, and red. And what you're trying to do is to keep people in the green amber zone. The amber red, it's too late almost. So you're trying to keep people away from that cliff edge. So
well, I was going to specifically ask, because when you're talking about vitamin C, though, you are talking about exceptionally high doses. So to put it in context, if somebody went and got effervescent vitamin C from the supermarket, that's 1 gram of vitamin C, or 1,000 milligrams. You're looking at something like in the region of up to 50,000. Super high doses.
Yes, I think some of these doses, there's a lot of talk of sort of going up to bowel tolerance. Now, I think there's a place for that, but I think there's also a place at the slightly lower level. And for the lower level, we're talking about more sort of preventative. What we're talking about is running at several grams a day. So if you use divided doses of vitamin C, and I think it's very important the form you take it in. There is some very, very recent information that's come out showing that ascorbic acid goes into the blood much quicker than the sodium form. So I recommend to anyone to actually take the ascorbic acid form of vitamin C.
And what does that mean practically? Because I guess vitamin C is a water-soluble vitamin. So even though there are some risks in terms of the stomach being irritated, it is pretty safe. But what do people tend to see in the supermarket?
It can be a mixture. It's more the sodium form, so it's more the buffered form, if you like.
I see.
Which is for me is a little bit of a problem. I really do think that the ascorbic acid form is more effective. It certainly goes. As I say, there's some very recent work that's just come out, and it's quite old. There's some work using a glucose meter, and it's been found that certain of these meters actually measure ascorbic acid. And what they've actually shown is that if you use well, this is a fairly high dose, a 10-gram bolus dose of ascorbic acid, it's going into the blood within minutes.
Wow.
And it's reaching peaks of anywhere between 5 and 10 millimolar within 3 to 5 minutes. Whereas the sodium form is taking much longer and never reaches that peak. So you sort of say, well, you know what's going on? It's peaking and then it's dropping quite quickly. So it's transiting into the blood very quickly and then disappearing. So tissues presumably are taking it up very, very quickly. Most tissues are going to be, immune cells are going to take it up very quickly. But just going back to this sort of dichotomy between low and very high doses. I mean, for the low doses, I would talk about a sort of maintenance dose. So I would, suggest people take anywhere between 2 and 4 grams a day as a maintenance dose, and take that as ascorbic acid. In terms of and take that with a good multivitamin. And yes, going back to the glutathione. Glutathione, possibly liposomal forms of glutathione would be useful.
Can I clarify, because it may not be clear to people? So why is vitamin C so important?
It's much maligned. I mean, it's I think we were just talking earlier about vitamins. What can vitamins do for a disease like COVID-19? Well, actually an awful lot. Vitamin C is just totally essential. I mean, normally we run at about 50 micromolar in blood. That level can be boosted by fairly low doses of vitamin C, so up gram a day, something like that. You can push it up nearly double. But there's a population. I was just looking at the papers recently that people can run it down to 20 micromolar or less, which is getting pretty low, and so that's okay. And well, it's not really okay, but it's certainly not okay when the body is stressed.
Yes, I see.
There's no bigger stress than an infection. So I'm just going to show this book from. It's a bit of a Bible, Hickey and Roberts. It was published in 2004, and one of the tables there, if I can go to that table, it's what it basically shows is that in infection. The levels of, well, it's not the level shown here, but it's the ratio of the oxidized to reduced form. And now I can't find the page, but let me just explain. The reduced form of vitamin C, the oxidized form of vitamin C, dehydroascorbate. So if you look at the ratio of ascorbic acid to dehydroascorbate in various disease conditions versus a control of about 20. So there's 20-fold more of the reduced form, the ascorbic acid, to the oxidized form, dehydroascorbate. In convalescent individuals, that can fall to 5. In those with the disease, it can fall to 1. And those unfortunate to die, it drops to half or less.
So you mean 20 to 50 times lower than what it would be normal?
Yes, and of course that's the ratio. That's not really telling you how much ascorbic acid is in the system.
Yes,
but the levels will probably drop to almost undetectable.
So can I clarify something about vitamin C, because you had mentioned this, and I think this is relevant. As humans, we need to take it in our diet. But the majority of animals are able to make it themselves. Now, Yeah, so
I mean, our house pets, the cats and dogs, are the equivalent. They'll be making about sort of 1 to 2 grams a day, the human equivalent.
mhm.
One of the biggest, or the animals that makes the most, is the goat. They make the equivalent of 13 grams a day or thereabouts. Primates are probably taking in an awful lot more vitamin C. So the various forms of apes are taking in more vitamin C. They're not actually making it. Guinea
Yeah,
pig is an animal that doesn't make vitamin C, and guinea pigs are not all that robust. Let's say that. And there's an interesting story around the atherosclerosis in guinea pigs as well, because that's another big aspect of the vitamin C story. So we don't make it. We seem to have lost part of the pathway. We've lost,
yeah.
but many animals certainly make it. And when they're stressed, it's been shown that the levels are increased enormously, so they can go up fivefold or more.
Wow. But we don't have that natural capability.
No.
And so the only way we can do it is by impacting on our diet.
Yes, indeed.
So let me just move on a little bit from the vitamin C. What about in terms of the hydroxychloroquine? I mean, this has been causing quite a lot of controversy in terms of across the world. There doesn't seem to be clear recommendations on it, yet people are using it all the time. What are your thoughts?
Yes, I mean, there's an awful lot of it's extraordinary. There've been papers in Science where there's been basically character assassination of some of the members, or certainly a certain member of the team in Marseille that's been looking at this, and almost unjustified. I think that there's problems in the way some of these studies are done. I think the work in Marseille is some of the initial studies were done with control groups, and then the later studies have been done without control groups. But certainly it's an ethical conundrum, isn't it? Really, that we've got a very, very serious condition. If you feel you have a drug that's working, it's almost it's a real ethical problem to have to rope in a control group. If you know that your therapy is working, and then of course you open yourself to the usual sort of criticism. I think from a fundamental point of view, I mean, I've always looked at hydroxychloroquine or chloroquine from a more sort of cellular approach, and looking at the story around autophagy or autophagy, where you've got a process that requires lysosomes for the degradation of components within the cell that are sort of surplus to requirements, or damaged mitochondria, for example. So you have a pathway where you can scoop up the contents of the cell that is not required or damaged mitochondria. I mean, the process is, I think there's a variation called mitophagy, where those damaged mitochondria can be reprocessed.
And so it's like a garbage disposal system.
Yes, it is. It is. It's the garbage disposal system of the cell. But one of the end points of that pathway are lysosomes. And I've sort of come at this from the cancer area, where like the autophagy process can be used by certain cancer cells to escape the effects of some anti-cancer agents. So one of the ways you can look at this is to block autophagy or autophagy, however you want to pronounce it, by using things like chloroquine, hydroxychloroquine, because instead of you reduce or increase the pH rather of lysosomes, and so some of the acid proteases stop working when the pH is increased. So when I first saw the work on hydroxychloroquine, I thought, well, okay, viruses often use that pathway for uptake. So they use the sort of endosomal. So you're taking in particles from the outside of a cell in vesicles. So these endosomes, so you can fuse. For example, the virus can fuse at, going back to this ACE2 site. So let's use this. So the virus is attached to the ACE2. It's then taken in by the membrane of the virus fusing with the membrane of the cell, and both of those fusing into a sort of endosome particle, and then that's transported through the cytoplasm of the cell to the protein production machinery of the cell, if you like. But you can use some of the acidic components of the lysosomes to actually break up the virus, releasing the genetic material that can then code, or then the RNA from this particular virus can then be transcribed by the RNA polymerase.
So let me see if I can get this right, because it's actually a very interesting and important point. So you're saying that when the virus gets inside the cell in their little packages, they then use the lysosomes to break down their, I guess, their cell walls to release their proteins.
Yes, to use the proteolytic enzymes and the RNA is released, and then the first stage will be a ribosome will then code or translate the RNA polymerase.
Yeah. So in effect, it means therefore that I'm just trying to see if I can simply explain the hydroxychloroquine concept. So therefore, by interfering with these lysosomes or these garbage disposal systems, you reduce the likelihood of the virus being able to replicate.
That's one of the possibilities, but I think it can act earlier on because the endosomes are somewhat acidic, so you actually increase the pH, which changes the transport of the virus, apparently. But I think that there's an earlier step that the hydroxychloroquine might be working, and that's the glycation of the ACE2 protein that may be blocked by chloroquine. So it may be interfering with the initial association of the virus.
So even preventing entry into the cell.
Yes, to block the entry. And then there are other stages. I mean, I was having this discussion online with some other people, and they're saying, oh, well, I'm not sure about the lysosomal story. As I say, I come at it from a cancer point of view, knowing that is one of the ways that hydroxychloroquine works.
Yeah.
And I think there's still the strong possibility that might be the way that the viral replication is inhibited.
Yes.
But then, of course, we've got this extra story with the zinc.
Yes, I was just going to go on to the zinc. So explain zinc. I really don't understand this one.
Well, I mean, zinc is obviously used in all sorts of pathways within cells. I mean, zinc is been, for example, with I don't know what you call it, sort of old wives' tale, if that isn't sexist, but still, we call it an old wives' tale. Zinc and echinacea, for example. It's something that's always been talked about for the common cold. Now, one of the possibilities, perhaps the echinacea contains polyphenols. Well, it does contain polyphenols. Maybe some of these polyphenols are acting like chloroquine. Now, the story with chloroquine or hydroxychloroquine and zinc, there's some work going back a few years now, looking at the two together, looking at how hydroxychloroquine could act as what's called an ionophore. It could drag zinc into cells. And if those cells have been infected with virus, the zinc been shown to inhibit the RNA polymerase. So to increase the concentration of zinc within cells, then that's what hydroxychloroquine was doing. Now, as I say, going back to the echinacea,
yes,
possible, I don't know, but there are other stories where things like quercetin, for example, may do a similar thing, that may be able to act as an ionophore and drag the zinc into the cell. And it's the zinc that may inhibit the RNA polymerase. And clearly, the RNA polymerase is a target, and various compounds are now being used to target the RNA polymerase. So, I mean, that's one aspect. In addition, So you could perhaps, and I think this I came across this a few weeks ago. I think there was some work being done in LA, where one of the ER medics there was looking at the combination of zinc and hydroxychloroquine, and it seemed to look fairly promising. I mean, zinc in itself may be boosting aspects of the immune system. I mean, it has a huge number of roles, so the two may not necessarily be linked, but then again, they might be. So it's just another part of the story.
So one of the things, as we're coming closer to the close, one of the things that has been almost disparaged or discounted in the scientific world is that looking at some of these vitamins is almost too simplistic. What would you say about that?
Yes, I think so. I mean, I think there's a wonderful quote here, and it happens to be from Winston Churchill. And it's man will occasionally stumble over the truth, but usually manages to pick himself up, walk over around it, and carry on. Well, I think this is what we do a lot of the time. I mean, how on earth can people say, how on earth can something like vitamin C be effective? Well, it can be. Just going back to the levels of vitamin C, the levels of vitamin C can drop enormously. So what you'll end up with a completely oxidizing environment, because once the levels of vitamin C drop, you will still need ascorbic acid. So in order to replace it, or not replace it, but to recycle it, you start to use glutathione. Mm-hmm. The levels of glutathione will drop. That will affect mitochondrial function in a very big way. And in fact, one of the things I'm considering is that this virus is actually, one of its targets is perhaps mitochondria. So some of the proteins it codes may be affecting, and I think this was found with SARS-1. There is some work suggesting that some of the proteins that the encoded by the virus, or gets our cells to make, actually target the mitochondria. So once you do that, you limit the ability to use oxygen. So the cells switch over to a much more, if you like, a primitive form. And this is one of the ways that vitamin C may be beneficial, and that there's a very important master switch in this change, and it's hypoxia-inducible factor 1. And when cells become a little bit hypoxic, or mitochondrial function is reduced, the levels of this protein come up, and it switches on a whole program of events. And a lot of those are actually switching cells from a more regulatory state. This is the immune system. So cells become activated. In other words, you go from a sort of fairly quiescent immune state to an activated immune state when HIF1 is switched up. Now, one of the important things of vitamin C is that it's the cofactor for a set of enzymes called prolyl hydroxylase and prolyl hydroxylase 3 is the enzyme that hydroxylates HIF1. And when it's hydroxylated, it's directed to a pathway that destroys it. So it's destroyed proteolytically. So the levels of HIF1 drop. Now that only happens with ascorbic acid. And it happens with the L form of ascorbic acid. It doesn't happen with the D form of ascorbic acid. So it's very particular which form of ascorbic acid. Yeah. So the environment that the cell is in, it's essential that there's enough ascorbic acid to maintain a low level of HIF1. Of course, we need the activation of immune cells, but we don't need too much activation, and this is the problem. We're talking about this cytokine storm where you've gone over the edge of the cliff, and it's somehow it's to drag that person back up the cliff. And that's the tricky bit. And can that be done with things like ascorbic acid? I think it can help. Preferably, you don't want to get there, so you want to treat people as soon as they're in the ICU, not leave it too long, and use intravenous ascorbic acid, probably with oral. If people are in a state that they can still take it orally, I would have suggested also oral ascorbic acid. You'd have to use the sodium salt for intravenous, but
Yes.
certainly use oral ascorbic acid with intravenous sodium form. Yeah.
Wonderful. Listen, I think this is fascinating stuff. I'm really, really happy to have had you, Professor Newton. So, one point as we're coming to the close here, I wanted to ask you, which is a little bit away from what we've spoken about, is that I know you are passionate about what could be health effects of 5G technology. And you've been to Downing Street to present a paper on that. Now, I've heard lots of rumors about 5G and COVID. Do you have anything to say about that?
Yes, I've kept well away from this. It's a big problem. People talking about this. 5G is not one thing. It's a system. It's not just the very high frequencies in the sort of 60 gigahertz or let's say 20 gigahertz plus. We've got frequencies very much lower, similar to the frequency we're using now. So linking 5G specifically with COVID is an absolute no-no for me. It should never have been done. People should never have talked about it this way. I think what we're surrounded by already is bad enough, but you can't just say there's a link between 5G and COVID. I think there is a problem with our background exposure, and what worries me most is our kids and their kids, because there is work showing that if you, and I don't want to necessarily worry people too much, but I won't say what context, but there is work showing that what we're exposed to already affects our oxidative status.
Mm-hmm.
So this can go back to the vitamin C story, if you like. So it increases the oxidation of various proteins and systems in our body, and that has been shown at a significant level of statistically high level of significance.
Yes.
And if you expose people to too high a level for too long, then our levels of oxidation go up. Now, that's not a good thing. That's an environmental stress, but I would not single out 5G. 5G hasn't been rolled out yet. When it's rolled out, we'll worry about it then. But I think we need to be more concerned about what we're exposed to now. And I would put it just as another environmental factor, but not specifically with COVID. It won't help, but I think COVID is bad enough on its own. I think that's
wonderful. Thank you very much, Professor Newton. It is wonderful to talk to you. I hope people understood some of that high-level stuff. And I just wanted to thank you again. And please keep doing that research. We need more persons like you helping to put this bug to bed.
Well, I hope it is some help. Thanks, Philip.
Thank you very much.
Talk to you.
Okay, then.
Bye now.